today's session. So today our topic is end of estimate. Topic is end of life care, and Garu. He's a section head of medical services and senior palliative care physician at Palliative India, and he's completed his CCPN course and NFPM, and he's a compassionate leadership with IAPC and international collaborators, and he's actively involved as a faculty in multiple palliative care education programs, both online and on-site, to build capacity among healthcare professionals. And he awarded the prestigious Bruce Davis Gold Medal in 2022 for his contributions to palliative care, and he is currently part of the Singapore-India Pact program and strengthening international collaborations in palliative care. Welcome, sir. Welcome for this session.
Thank you, ma'am. Thank you, ma'am, for the warm introduction. A very warm good afternoon to everyone, and welcome to today's session on ethics and end-of-life care. Am I well audible, ma'am? Am I audible?
Yes, sir. You can continue.
Oh, thank you. So, we have had multiple sessions in palliative care, and end-of-life care is a very important part of us. Though there is a misnomer that palliative care is just alone end-of-life care, palliative end-of-life care is a part of a very important part of palliative care. As we know, that is inevitable. It will come one day. So when a patient comes to you nearing end of life, the goal of care should be to minimize the distress by a meticulous symptom control and supportive care while maintaining well-being and moral integrity. So our aim is ideally to reduce the suffering. And all patients have the right to adequate relief of physical and psychological symptoms and social support. Please keep this in mind whenever you're seeing a patient. We plan to reduce the suffering. So what is a terminal phase? This is a period of irreversible decline in functional status prior to death. It might last few hours to days and occasionally weeks. So we need to assess. So whenever we need to focus more on the care, we have to assess whether this patient is nearing end of life. So that is that recognizing that a patient is immediately dying is very important. Why? Because we need to provide the patient and the family with information on what to expect, so they can set the meaningful goals, priorities, expectations of care, go on the plan of care, like how to go forward, or decision should we take regarding interventions or medications, what else? Is there some wish they wanted to get done with in this time? And it's a technical prerequisite for medical clinical decisions also. So how to prognosticate? There are prognostication, like telling them what we expect. We have three phases. One is formulating the prognosis. Second is communicating. And third is utilizing this decision when we need to make a clinical decision. So a prognostication can be done in two ways. One is a clinical prediction of survival. Like it's a subjective judgment and formulation of prognosis in our clinical. We call that a surprise question. So this is a question we ask ourselves. The treating personnel ask ourselves, whether will you be surprised to see this patient after 6 months? So if the answer is yes, that you think you will be surprised to see this patient after 6 months, you can consider this patient as nearing end of life. If it's a no, we need not consider him as an end of life situation. So this is just a prediction based on our knowledge of the patient situation. Second is an actual treatment, like depending on the statistical data and how much time he might have. So certain symptoms which are indicating that the patient is nearing end of life would be from severe weight loss, profound weakness and fatigue, social withdrawal, disinterest in food and drink, dysphagia, and difficulty in swallowing, even medication, refractory delirium, which is not responding to medications, changes in breathing pattern, being drowsy for extended periods without much causes, reduce urine output, and the skin becomes cold to touch, and a waxy looking skin. So these are certain symptoms which are indicating that this person is nearing end of life. So what are the informations like there are certain things we have to keep in mind when we are managing a person nearing end of life, like information and communication. Talking with the family, communicating with the loved ones and the patient regarding what to do at the situation, evaluation of the family needs and resources, looking what they wanted to know, what they have to do, their cultural practices, care education. So nearing end of life, this person will be needing more support rather than he was before. So there should be adequate educated taking care of them. They may not be able to do their activities of daily life. So the family needs to be educated on how to provide care for and keep reviewing the family's coping. Are they coping it well? They are ready. They are also in acceptance, or are they bargaining, or are they in denial? So those things should also be taken look at. And care of the family when patient is unconscious. He is nearing end of life and he is not able to respond, but the family is surrounding him. They might be in too much of psychological distress. So take care of them also and preparing them for the diagnosis. These are expectations we have to do in the terminal phase. Certain things that we need to keep in our mind while helping a patient in nearing that would be like one of the things is discontinuing non-essential medications. It's very often we see patients with a good big number of medications. Even in their situation, they are nearing end of life, which do not contribute to the patient's quality of life. So we might have to identify and stop medications that do not improve his comfort. Likewise, other investigations which may not be causing much change in quality of life, but has been prescribed. So such things we can avoid in such situations. And make sure whenever you are doing this, like you're stopping certain medications which may not be. So think of atorvastatin. There won't be much indication like for continuing atorvastatin in a very elderly or nearing end of life patient. So what we expect is there to prevent any adverse cardiovascular event, which is not a primary concern in such a situation, who might die within a few hours or days. And make sure that you are reassuring the family that we are continuing care, but the goal of care has been switched to comfort. We are trying to make the patient comfort as much as possible. We are not denying or stopping the treatments. We are continuing care with the aim of making him comfortable. And always make sure medications for pain and the symptom control, like nausea, vomiting, or restlessness, should be continued. No way they should be discontinued. And route should be converted from oral to transdermal or parenteral routes. Ideally, subcutaneous is preferred as it's less traumatic and less issues for them. And loss of ability to swallow in terminal phase should be anticipated and planned for as needed medication so that the patients are not left with the rickets. So changes in that, the swallowing, or we may not be able to depend on the tablets, or there could be certain symptoms which come up in that situation. So keep in mind in managing that also. Pain, do not discontinue analgesics in a dying patient. Ensure availability of medications given by preferably non-oral route. Often, as we said, the swallowing might be affected. So we have to look for alternate routes of medications. preferably subcutaneous or transmucosal, transdermal patches, or nasal sprays, sublingual, parenteral medications, all those. And make sure you review the need for these medications. So one other common symptom in nearing end of life would be dyspnea. Like around 70% of patients nearing end of life would face this and can often be more refractory, that is not responding to medications only. Here we might have to employ smaller doses of opioids to reduce the distress. Benzodiazepine can also be used to reduce the panic and anxiety. Oxygen therapy in an end-of-life situation, we can give it a trial. We can give it oxygen for 10 to 15 minutes, and if distress improves, we can continue oxygen therapy. Otherwise, we might have to think about stopping them because he might not be in a situation where oxygen would be helping him. But if it helps him reduce the suffering or distress, we can continue. And also look for the non-pharmacological measures of dyspnea. If errors also, Dr. is very difficult to watch for a person to be breathless. So, in case severe distress and is persisting, we might even have to plan for palliative sedation. Delirium is in up to 88% there could be seen. It could be hyperactive or hyperactive, very much distressing for the family or the caregivers, and it's even a poor prognostic factor. So, in a patient with nearing end of life, as in a normal person for whom when he presents with the delirium, we need not look into the cause of delirium because he is terminally ill. A correction may not improve the quality of life for them, and symptom management would be the ideal choice, where we can use medications like antipsychotics, the haloperidol, levetiracetam, risperidone, olanzapine, and benzodiazepines as needed. Thermal secretion of death rattle. During the last few hours, there will be thermal secretion, which is always known as a death rattle. So we doesn't know the exact mechanism, but the pooling of saliva and secretions upper gas airway, and as he's nearing end of life, his swallowing muscles would be not properly functioning. So it pulls inside and causes a sound. Thing to keep in mind is this is not distressing to the patient, but this sound would be distressing to the family. We use antimuscarinic agents like lycopyrrolate or atropine for this knowledge. The most common question people ask us is nutrition. What if, doctor, my father or mother is not taking properly, is terminally ill? What can we do? Can we put an oil tube? Or can we do a peg? He's not feeding. Can I force feed him? So, as we know, in our situation, like we express the love through food, and it's very distressing for the family to that the patient may not be taking normal food as normally or even in smaller quantities. So, excuse me. Okay. So as a patient's conscious level deteriorates, aspiration risk is greater, and this versus benefit of oral intake with regard to aspiration need to be explored with the family. So we talk to the family in detail, advise them of the oral intake at the stage. It might be declining, so we might need to look for more comfort. A few lines about palliative sedation. This is an option in terminal phase if refractory suffering is present. And even a low minimum level of sedation is required to adequately manage the refractory symptoms, and suffering is removed. Coming to ethics. So we need to know more the 4 principles of ethics in adult practice in the patients. This is not just applicable for end of life. This is applicable to each and every patient whenever you are doing an intervention or change or care. So keep in mind the 4 things are autonomy, beneficence. That means do good for the patient. Non-maleficence. Whatever you do, it should not be harm for the patient. And justice. They all have equal weightage in each situation. So, as I said again, nearing end of life, we always have to think for the potential benefits of the treatment versus potential risk and burden also. Um, Striving to preserve life, but if burden of life-sustaining treatment outweighs potential benefit, we have to think about making the patient comfortable. So this is a question I want to ask everyone. Have you ever thought of your own death? Have you all thought about your death? I'm sorry to disclose that each and every one of us is going to die one day. Have you ever thought of what happens?
Participants, please respond now.
So if you think you have thought about, or if you haven't thought, these are two options. Which do you think is a better way to go? Option one is a lady who's terminally ill at her home. You can see her daughter is feeding her water. She's in her bed in her room, surrounded by her loved ones. Second is someone who is inside an intensive care unit connected to a large number of machines and tubings. Which do you think is a better way to go? Anyone?
First one, sir.
First one. Thank you, Conrad, sir. So why do you think that is a good option?
Because it is one of the peaceful death with the love and care of his dependents, and he or she can fulfill his final wishes before going to die.
Yes, sir. Thank you for that. Thank you for that answer. Wonderful answer. So anyone has any objections? I hope there are none. So I want to this session coming will be more interactive. So I wanted your opinion in situations because ethics is something that I cannot teach you in a session. It's more of a process that comes. So should be a thinking process. So this is situation. A 70-year-old female with carcinoma lung, hypertension and diabetes has come to you. She's very cachectic, bedbound and dependent on all activities of daily living. She's brought to a hospital with reduced oral intake, diagnosed with aspiration pneumonia and end-stage renal disease. You have you have advised antibiotics and dialysis for management. The patient, of course, says she doesn't want to do that. She refuses the treatment, but the sons want her to undergo dialysis and rice tube insertion for a reduced food intake. What do you think we should do in such situation? So what should we do in such situation?
Kindly respond. As we call-
Patient's priority is foremost important. Without the patient consent, we cannot have the rights to touch and do harm anything to the patient. First thing, and if at all, if the patient is accepted according to the request from his relatives or his bystander, then we can proceed further for his treatment.
Here the patient has clearly refused, but her bystanders, the sons, have want to undergo dialysis and NG2. So should we go for dialysis or not?
Yeah, in treatment wise, we can, the progress of the treatment, the next step, how the prognosis will be there. If it is good, then we can extend our life for 6 months or 3 more months or 1 year. In that period, is it like that means we can give treatment?
Sir, one more message is here in chat box.
Okay.
The patient has the right to refuse treatment, even if her family disagree. Respecting her decision is ethically important.
Okay, thank you for that response. So we'll discuss this further. Okay, so will you advise this patient to cover certain and NG2 antibiotic dialysis? So all the answers I received were they will not. Will you avoid talking and discuss the treatment with the relatives alone? And will you respect the patient's wishes? I think we have clear responses from the team. And will you refer to higher center? So to answer this, before going to that ethical decision, so I want to tell one thing. This came out of the ICMR. Right? The primary objective of healthcare professional, any patient is to mitigate suffering. It might be cure sometimes, relieve often, and comfort always. There is no exception for this rule. So our aim is to make the patient comfortable. So here is the first principle of ethics: is autonomy. What the patient think decision. So who makes the decision? The doctor, the patient, or the family? As you mentioned, the patient has the right to decide. If he's in sound of mind, we have the patient's wish has to be respected. And when we are making this, we have to consider the social cultural context and expectations of the family also. Or if not, we have to communicate to them clearly. So before agreeing to the patient's wishes, we have to look whether the patient has decision-making capacity. Is she able to understand the situation she's on? Is she able to appreciate the choices available? Like you can offer two ways: either the surgery would be the treatment of option, or nothing. So where we can assure that there will be. So if you do the surgery, this will be the outcome. If you do not do the surgery, this will be the outcome. So everything should be explained to them, and she should be able to appreciate both the choices available and reason the benefits and burden of the treatment. She should be able to rationalize and ability to communicate and the goals and aspirations. So autonomy is like our relationship with the patient. We respect for patient privacy and confidentiality. There should be empathetic truth telling, not sympathetic, empathetic. We should be standing on their own shoes, knowing what they are going through, and help them, tell the truth to them. Do not hide anything. And all the choices that you provide them for care should be properly informed. Sufficient amount of information should be given to them. And decision making should always be shared decision. You alone should not be taking. You have to involve the patient and the family. Because considering our cultural situation, a shared decision would be better option. And collective autonomy is the norm of our culture. So this should be correct. Like you can see the doctor giving him very puzzled, jungled options about the treatments, benefits, harms, and this. So this is how an informed consent will be given. No. So the consent should be given clearly, and all the choices should be explained properly to them, and the patient should be in sound of mind enough to understand that and take a decision knowing the implications. So these conversations should be between these experts. You are the expert in healthcare. The patient is a layman, but he is the expert on his own matters and his life. Sorry. So we are experts in our own healthcare, but the patient is the expert on himself and his health. Patient autonomy is to be upheld at all costs in medical. Suppose this patient had dementia and lacks capacity to take decisions for herself. Then what can we do?
Then patient attenders.
So then there comes a question like who should be the surrogate decision maker? Next of kin, who will be there? Is there a nominated person? Are they legal issues? And are they taking the decision based on best interest for the patient? That should also be considered when you respect the surrogate decision maker's concern. And look for advance directives. Is there a living will or a medical power of attorney has been already made by the patient? Is then we are legally bound to respect this. So when patient autonomy is compromised, we have to think for beneficence. And beneficence is our relationship with the outcome, where we are determining the best interest of the patient. It's an act of obligation to act in the best interest of the patient, like do good for the patient. So am I fixing? So these questions should come to our mind when we are depending on beneficence. Am I fixing what is wrong? Am I effectively managing the disease process? What is the burden versus benefit of the treatment you are going to offer? If you're starting a tablet, there could be two ways. Like it could be a burden, there could be adverse effects or side effect profile, and there could be also beneficial. So you should weigh both and give in such a way that we do good for the patient. And you should know what is the risk and how much suffering or distress this can cause to the patient. And am I simply delaying the inevitable? So is my intervention, which I'm planning to do, simply prolonging his life, but not the quality of his life? What is the expected prognosis with or without the treatment, and in terms of survival and disability? So will this do any good for him? This even if I do this intervention, will that improve the quality of life of him or survival and disability? So all those things should come in mind in terms of beneficiaries. Another story, a 20-year-old boy with a metastatic osteosarcoma of the lower and the femur, ligaments and anemia. He has a large tumor on his thigh and insists on getting operated. Both parents and patient is adamant regarding the operation. What should the surgeon do? You are the surgeon. What do you think should we do? Here, the patient autonomy is like patient wants a surgery to happen, but think this same metastatic osteosarcoma patient with the ligaments and anemia. There's a large tumor in the thigh, and he wants a tumor to be removed. Patient and families keep on telling you to do the surgery. So, as a surgeon, what should be you doing?
Can operate. We can operate and we can prolong his life as much as possible.
Okay, thank you, sir, for the info. Like you said, you might operate for them. So you are respecting the autonomy. I agree you are disagreeing, sorry, agreeing to uh, following the ethical principle of autonomy, agreeing to the patients and wishes. But think about what they have to go through this. Metastatic cancer with already non-ligaments and anemia. So what are he has to face through the surgical process? There could be PS, getting a PSC would be very difficult. Pre-anesthetic checkup could be very difficult considering the situation. Anemia correction has to be done. And so there's a high risk of cardiac events because of anemia. Lung metastasis is also being, and it's already an extensively spreaded disease. So it's going to be major surgery. So the post-op care, the surgical, the stress on the surgery, post-op care, all those things. So even if you do, is it going to do any good for him? So that thing also should come into mind. There are times when autonomy is also to be challenged. So non-maleficence is what we think is do no harm for the species. We respect the sanctity of the life, and this is a right of us as a treating person. There are situations where we can see maleficence overrides autonomy. So the patient wants to do this, but unfortunately, when you think about this patient, what are the benefits of doing this surgery? That's a debulking thing. Psychologically, the family and the patient would be happy because you have done the surgery, because for this. But when you weigh against other situations, so anesthesia thing, post-op care, the pain are going to suffer for the surgery, anemia. So there is the harm pathway is much more heavy than the benefits. So doing no harm is also ethically our responsibility. The patient or the family may not be aware of this situation. They may not be able to aware about the benefit, the harm situation. So we have to think about that. So whenever we are managing a patient, and the four ethical principles should be considered, and at times we have to give weightage to certain ones and certain conditions. So as if I was the one, so demand for a specific medical therapy that is devoid of clinical evidence in the given situation, or the request from family to withhold medical information, conflict of opinion among the family, sorry, or the healthcare providers is also a conflict. So these are situations we have to think more about the maleficence, non-maleficence, that is providing no harm for the patient. So if I was a patient surgeon, I would suggest against a surgery, even if they are asked. I will try to communicate with them about the benefit and harm. And rather than doing harm, I would not do the surgery. So many often they will be coming back to us. So they will be strongly adamant. Then the ideal situation that I would ask them to get a second opinion. That I will not do the surgery because this is going to do more harm for him. I am aware of that, so I will try to communicate. And even if they listen, I would suggest to get them a second opinion. Considering the situation, they might get the same opinion that we has taken, and they might be able to come into an acceptance. One thing you need to know is the doctrine of double effect. So this is a doctrine of double effect is a single act having two opposing effects, one good and one harmful, and it's not always morally prohibited if a harmful effect is not. So consider the situation of managing an ectopic pregnancy, we might have to remove the salpinges. So a salpingectomy is so the salpingectomy is an intervention we are doing. So it has two possible effects. One is life-saving, where it's life-saving by removing the ectopic pregnancy. Other, it might cause further infertility issues. So there are two possible effects for this salpingectomy. One is good and one is harmful. And this is not morally prohibited if harmful effect is on. So we are doing this salpingectomy to save the life and prevent because of the ectopic pregnancy. So this we know there could be more fertility issues, but our intention is good. So this is not a morally prohibited. So that must be morally good, and we have no desire for the negative effect, and both should be immediately. The good effect should be as immediate as a negative effect. Like this one more situation, I would say, like in nearing end of life situation, end of life case, the patient with severe respiratory distress, we would be giving morphine and benzodiazepines to make him comfortable. So here also these medications have two outcomes. One is reducing the distress, and other would be causing respiratory depression. So we know there are two foreseen effects. One is good is reducing the suffering, the bad is respiratory depression. Here we are ethically, it is safe to administer this medication because we are intending to reduce the suffering and not intending for the respiratory depression to come in. So another situation where a 57-year-old gentleman with advanced metastatic cancer of lung comes to you with severe metastasis due to progressive disease. All reversible causes of disease has been ruled out. So it's probably the worsening of the disease, and he is admitted into ICU for artificial ventilation. What do you think about this situation? Should we go for this? Should we admit this patient to intensive care? Should we intubate him, or should we restate him if he has? So here also, often like we might be thinking in normal situation he would be admitted in intensive care unit and intubation, resuscitation, all will happen. But what if like this situation happens in a very necessary time where there's only one ventilator available in the hospital, and this person comes very advanced metastatic lung cancer, severe breathlessness, but nothing is correctable, so you need artificial ventilation. At the same time, you see there is a 23-year-old young man post RTA requiring artificial ventilation as brought in. So whom will we give the bed to? There is only one bed for the So we have 57-year-old metastatic carcinoma lung patient without any correctable condition and a 53-year-old young man with post RTA, the probable improvement situation. But we have only one bed. Which should we give? For whom should we give the bed? So to take a decision on this, we have to think about the four principles of justice. So as you know, healthcare is a very scarce resource. Equitable access to resources is an ideal situation. So everyone has a equitable. It's not an equal access. It should be equitable. So according to the patient, we have to think about that. So this situation, the ICU bed is a very precious resource. Whom should be allowed and how can this? Is there justice to allocate this ventilator, artificial ventilator, to someone who is terminally ill without any correctable causes? Whatever we do, he might die within a few days. But otherwise, there is a chance of allocating it to a person with a very young patient with a chance of recovery. So why or whom should we give it ideally? That is a question. This principle has to be considered. And for the first patient, we are not abandoning him. We might be able to provide him with comfort care. That would be the best option we could provide for him. So the study states that end-of-life care consumes around 20% of healthcare expenditures, and our duty is to individual patient and society as a whole. Many conflicts in cases with limited resources. So assessing the futility of management should be very imperative. So futility as an excessive aggressive medical intervention in terms of effort required or financial resources utilizing a little or no effect in the clinical outcome. The patient does not improve in terms of his quality of life, or is it whether it is doing more harm for him. And the questions that we can ask is, does not slow the disease progression. It will not sustain will not reduce the disability, and will not improve health or discomfort. There is no change in quality of life of the patient. So such situation we can call it as a futile intervention. So the treatment that does not provide benefit may add more distress to the patient is ethically and legally withheld or withdrawn. Our goal of medicine should be shifted to comfort of palliation of symptoms, and there is no ethical difference between withholding and withdrawing. So withholding would be so this patient is brought to your intensive care hospital, so requiring ventilator. Think about the lay person. Then a person with advanced metastatic carcinoma lung, severe metastasis coming to you, there is a ventilator. So should we give it to them? That's a life-sustaining treatment. So withholding, avoiding that, not starting them it for them, considering the futility of the management would be considered as withholding. Another situation would be withdrawing, where this patient is already intubated and he is not improving the quality of life, or the continuing the ventilator is causing more harm for him. So that's called a withdrawal situation. So euthanasia is the intentional act of ending a patient's life by medical means at the request of patient family with an objective to end or avoid suffering. It's illegal in India, but there was a rule, Supreme Court order where it was making passive euthanasia as illegal. So euthanasia is always an active, so it's a misnomer. So there has to be an intervention to do that. Even if you have stopped feeding the patient, there is an intervention we are doing. So euthanasia is always active. The advanced medical directive is an advanced, or also known as a living will. You should know about this because it's an exercise of autonomy of the patient. Like I can make it legal document that when in a situation I am having a health-related issue, in a situation where I may not be able to express my feelings, I want these things to happen, or these should not be happen. Like I can write it that I do not require ICU admission or dialysis or ventilator support, but can continue as a palliative care support. So that can be documented. And once it is signed by a gazetted officer or a notary, this becomes a legal will, and so legally valid and has to be respected by any healthcare professional. To always keep in mind, give only realistic treatment options, allow time, continue exercising measures till they get a decision, accept decisions for partial support, and avoid reinforcing sense of guilt in the family. You are trying to help them. They are at one of the worst phases of their life. So sometimes like withdrawing a futile intervention would be, they might feel it as a guilt for them. Like they later might feel that they are harmed the loved one. And so we should not do anything to reinforce put that sense of guilt to them, and never say there is nothing more to do. So this patient, there is nothing more to do, should never be told there is things to do that we need to do to make him comfortable, and make sure they are assured the care will continue to be available despite whatever the decision they take. So the most fundamental principle of medicine is love. And thank you. Thank you for listening to me. And shall we open for questions?
Dear participants, if you have any doubts, please ask. Sir is here to clear your doubts. This is our last session, sir,
Oh,
for this project.
okay.
Anyone having any doubts? Kindly respond.
Is there a case discussion today? No?
Everyone say thank you.
Is there a case discussion today?
Thank you, sir. Thank you so much. This is dear participant. This is the last session for this team. This batch, not project. Sorry, and it's a wonderful session, sir. Thank you so much.
Thank you, ma'am.
It's time to wind up.
Sure.
Thank you. Thank you, everyone.
Thank you, everyone.